Dr. Usha will be speaking on optic nerve fenestration technique and outcome. She's the past president of OPI and a teacher to a whole generation of oculoplastic surgeons and an inspiration to every one of them.
Thank you for those nice words. Thank you very much. I will be talking about optic nerve sheath fenestration. Now, just let's look at what is available for the raised intracranial hypertension. There are CSF diversion procedures, that is the ventriculoperitoneal or the lumboperitoneal shunt, the optic nerve sheath fenestration, transverse venous sinus stenting, the efficacy of which is debatable, and the bariatric surgery for the weight loss. Now, it was D. Wecker who initiated the treatment of papilledema by performing the optic nerve sheath decompression excuse me, using his own peculiar instrument through the conjunctiva without any visualization of the operative field. Now, Hare in 1960, he artificially produced papilledema in an animal model and demonstrated that creating a window in the dura of the optic nerve sheath produces bilateral relief of optic disc edema. This was the background that we have. And the mechanisms of fenestration, the obliteration of the subarachnoid space surrounding the optic nerve by fibroblast proliferation, preventing the CSF pressure transmission distal to the operative site, and creation of a dural fistula which allows the egress of the CSF. So we'll have definitive indications for optic nerve sheath decompression or fenestration, progressive loss of vision, papilledema that's refractory to medical therapy. These are the indications that we have to keep in mind. And the options that we have are a lateral approach or a medial approach. Lateral approach could be a lateral orbitotomy with or without bony flap removal. And a medial approach will be medial transconjunctival or a superior lid crease incision. It's performed under general anesthesia. A high-risk consent has to be obtained, and you have to definitely give a guarded visual prognosis even in a seeing eye. So with this background in mind, let's go through this case history so we'll understand it a little better. A 17-year-old woman with sudden painless loss of vision in both her eyes, restriction of lateral movements of both eyes of 2 days duration, repeated headaches over a year, neck stiffness, pain with a little bit of pain, treated as a case of migraine, which is quite common, and 3 episodes of headache per week. So an MRI was done obviously, and it showed a normal study. On examination, patient was obviously normal otherwise, with a weight of about 79 kgs, which is to be noted, and a blood pressure of 170 over 120. Other systemic examination was normal. So with papilledema both eyes and a typical picture like this, as you see, her visual acuity in the right eye was PL plus PR inaccurate, and left eye was hand movements. Pupil was dilated and fixed. And there were movement restriction. Adduction was restricted. The next day, the patient had right lower motor neuron type of 7th nerve paresis, right proximal upper limb paresis, diminished plantar response, and worsening of the neck stiffness and pain. And rest of her profile was normal, except that her CSF opening pressure on lumbar puncture was 12 centimeters of water, and CSF analysis showed an increased protein. With this in mind, the treatment by the neurophysician, that is a neurologist, was IV mannitol, Lasix, Diamox, and steroid injections, antihypertensive medications, and ATT was empirically started. However, the TB PCR seemed to be negative. A visual acuity of right eye hand movements and left eye 624 was obtained. Then a repeat MRI was done, which showed a dural venous sinus thrombosis. Now for this, we went ahead and did an optic nerve sheath fenestration. As shown, you make a conjunctival incision, isolate and disinsert the medial rectus, and you elevate the globe and abduct it Keep monitoring the pupil. Go along the posterior ciliary artery, and you use your MVR blade or a paracentesis knife. Now recently I've started using the paracentesis knife as well. Make a nick on the optic nerve sheath carefully, and you can see the gush of CSF, and you can make multiple nicks in order to create a window. You can use a scissors. It's easily said but can never be achieved very easily, so I try to do the multiple nicks and connect them all. You can use a myringotomy scissors. You can borrow it from the ENT friends, but it's not very easy, as I said. And when you make multiple nicks and connect them, you create a window. Once this is done, you can reattach the medial rectus muscle carefully and close the conjunctiva. Now the vision in the right eye became 624 and the left eye was 6/9 partial, and the restriction was only -1 post-op day 1. Day 2 6/18 improved to 6/18 and the left eye 6/9 partial. There was resolving disc edema both eyes. Right eye showed a pallor, blood pressure came down, and this is the fundus picture. You can also see the thinning of the edema is reduced post-operatively, but you can also see the secondary optic atrophy. So if you look at the course of events over a period of about 11 months, vision corrected over to 6/9 in the right eye and 6/6 in the left eye, though there was peripheral constriction of fields, but the extraocular movements were full in this particular patient. So the next, I went ahead and explored the other options also. I started doing the skin crease approach, and here again you can go directly to the optic nerve. So the one point that I'd like everyone to remember is, please do not choose an obese individual for a skin crease approach, because the fat is going to really be in your way and will never let you reach the optic nerve very easily. But in a thin individual, you probably can resort to doing a crease approach. And even as you puncture very minimally, you will start seeing a minimal fluid trickle. Sometimes it may be difficult to approach, but once you make multiple nicks, then you can see the fluid seeping out, and you can use gentle suction, and you will see that it keeps seeping through. So this is a real easy procedure when approached from the lid crease, but care to be taken that you only choose patients who are not very obese. Now again, this I'm trying to show another case where we went ahead and did the release of the fluid, and you can see that you can see the opening as well, but that's not adequate, so you need to make multiple nicks and connect them all. So if we keep making the multiple nicks, you can you'll almost have a very good window made, and you reattach. You can even avoid disinserting the medial rectus muscle. So in conclusion, patients who fail conservative and maximal medical therapy for papilledema and headache require surgical intervention. So optic nerve sheath fenestration for patients with predominantly visual symptoms, they are the good patients for such fenestration treatment. And the shunts for patients with headache. So one strong message is, if there is headache, we can go for shunt, but when there is more of a visual loss, I think we should resort to fenestration. And this message has to be given across to the neurologist, because it's often very late that they refer these patients to us. So in our experience, we took about 102 eyes of 83 patients. 20 patients had bilateral papilledema, and visual improvement was seen in 37% of cases, that is 38 cases. Worsening was seen in 34%, that is 35 cases, and no visual improvement is seen in 28 eyes, which is 28%, which is 29 patients. So there are cases which have improved from no PL to 5/60, which is again to be kept in mind, it was a recent onset, so it was referred early to us. Cases improved from 5/60 to 6/12, and there were 6 cases which underwent prior VP shunts as well. So the most common indication is IIH, raised ICT of unknown etiology. Most common symptoms are early morning headaches, transient visual obscurations, visual field loss, double vision, sixth nerve, paresis. So good prognosis is seen in patients with good initial presenting visual acuity, shorter time for intervention. Unilateral surgery had better prognosis for both eyes than did bilateral surgery, and acute visual loss likely to improve than chronic visual loss with poor acuity and irreversible optic nerve damage. Thank you very much.